Venkatrao sir, welcome.
Yeah, good morning, sir.
Good morning, sir.
Hello.
Good morning, sir. Good
Yeah,
morning.
good morning. Professor Murthy here.
Yeah, good morning, sir.
Good morning, good morning, good morning.
Sir, good morning.
Sir, good morning. ಹೇಗಿದ್ದೀರಿ?
ಚೆನ್ನಾಗಿದ್ದೀನಿ ಸರ್, ನೀವು ಸರ್?
ಆರಾಮ?
ನೀವು ಹೇಗಿದ್ದೀರಾ ಸರ್?
ಆರಾಮ್ ಸರ್, ಆರಾಮ್ ನಡೀತಾ ಇದೆ. ಇವ್ರಿಗೆ ಸ್ಕ್ರೀನ್ ಶೇರ್ ಫೆಸಿಲಿಟಿ ಕೊಟ್ಬಿಡಿ ಇವ್ರಿಗೆ. ಗೌರಿ ಶ್ರೀನಿವಾಸ ಮೇಡಮ್.
ನಮಸ್ಕಾರ ಸರ್. ನಮಸ್ತೆ ವೆಂಕಟರಾವ್. ನಮಸ್ಕಾರ ಸರ್. ನಮಸ್ಕಾರ ಸರ್. ಮೇಡಮ್ ವಂದನಾ ಮೇಡಮ್. Madam, first we will have to allow Madam to enter Gauri Srinivas.
Yes, sir.
Right? Somebody should
permit her to share the screen.
And also you should share the screen.
Yes, sir.
Otherwise, you can make her as the co-host.
Yeah.
Yes, sir. Yes, sir.
Making her as the co-host is the best thing.
Yes, sir.
Upon joining, you can make her.
Yes, sir.
ಸರ್ ಕತ್ಲಿದೆ ನಿಮ್ ರೂಮ್?
ಲೈಟ್ಸ್ ಸ್ವಲ್ಪ ಕಮ್ಮಿ ಇದೆ ಸರ್, ಲೈಟ್ ಆನ್ ಮಾಡ್ತೀನಿ ಸರ್.
Good morning, ma'am. Good morning, ma'am. Good morning, Gauri ma'am.
Good morning, ma'am. Can you hear me?
Yes, ma'am. Can I make you co-host, ma'am?
Yes, certainly, ma'am. Is it okay for me to share the screen for the slides?
Yes, ma'am. 1 second. I'll make the co-host and I'll give the option for the share screen.
Okay, okay.
Madam, this is Prasamurthy here. Good morning.
Good morning, sir. How are you?
Oh, fine. How are you?
Fine, thank you, sir.
Good morning, madam. This is Dr. Ram Narsimha, Principal KSSEM.
Good morning, sir. So
Good
nice
morning.
to meet you.
Thank you. Thank you.
Good morning, Srinivas here.
Good morning, sir. How are you?
I hope you remember me.
Sir, of course. So nice to meet you here.
We have been wanting to see you.
So nice, sir.
Gauri Srinivasa madam, namaskara. VKM madam.
Namaskara, sir. Wow. It's just so nice. Very nice to hear your voice.
Yeah, he has joined DSU
Oh, wonderful.
as research professor.
So nice. So nice, sir.
Thank you, madam. Thank you.
Oh, there's only one route.
Sir.
Sorry for interruptions. Ma'am, you can share the screen now.
Okay. It says host disabled participant screen sharing.
Yeah, you can make as a co-host.
Yeah, I made it co-host, sir.
No, it's not
Yes.
effective.
Yeah, 1 second, 1 second.
Sure, sure.
Yeah, now it's going to work.
Okay.
Madam, try it out.
Yes, sir. I think it's. Is it visible?
Yeah, yeah.
Okay.
You can make it full screen and probably it works. Yeah,
Yes.
perfect.
Thank you so much. Is there a lag or anything? So should I speak a little slow when the screen changes?
No, there's no lag at all. No lag at all.
Okay.
It looks perfectly okay.
Okay. Thank you.
Sir, we'll wait for another 5 minutes. At 9:30,
Yeah.
more people will be joining.
Okay.
Gauri ma'am,
Yes, sir.
candy store.
Yes, sir.
Engineers don't get diabetes, is it?
No, sir.
Joking, madam. Yeah.
Yeah, scientific purity.
Sorry, sir. I didn't hear that.
We have scientists to cure the diabetes.
Yes. It's really nice. VKM sir is also here. This is his field basically.
Viraj sir, this is Prasamurthy here. Viraj Kumar has joined, madam.
Oh wow, so nice. Hello, sir.
His audio is, yeah, now it's his audio is good work.
Audio is still muted.
Video on. So very good morning, sir. Can we start or will wait, sir?
Yeah, another 5 minutes.
Yes, sir.
There are a lot of people who are just waiting.
Yes, sir. Yeah, admitted, sir.
Good morning, good morning. ಇಟ್ಟಿದೆ ಲೆಕ್ಚರ್ ಇದೆ ಕಳ್ಸಿದ್ದೀನಿ. ಇಲ್ಲ ಇಲ್ಲ 9:00 ಸ್ಟಾರ್ಟ್ ಆಗಿದೆ. ಇಲ್ಲ ಇಲ್ಲ ಇವರು ಗುರುಶ್ವಾಸ ವಾಟ್ಸಪ್
ಶುರುವಾಗಿದೆ ನೋಡಿ ಸರ್ ಪ್ರೋಗ್ರಾಮ್. ಸುನಿಲ್ ಸರ್ ಕಳಿಸಿದ್ರು.
ಮೇಲ್ ಕಳಿಸ್ತಾ ಇದೆ, ಮೇಲ್ ಅಂತ ಹೋಗ್ಬೇಕು ಅಷ್ಟೇ.
ಡೋರ್ ಕ್ಲೋಸ್ ಮಾಡ್ಬಿಟ್ಟಿದೆ. ಯಾವುದೋ ಮೀಟಿಂಗ್ ಅಲ್ಲಿ ಇರ್ತೀನಿ, ಏನೋ ಇದ್ರೆ ಬನ್ನಿ, ಪರವಾಗಿಲ್ಲ, ತೊಂದರೆ ಇಲ್ಲ, ಆಯ್ತಾ?
ವೆಂಕಟರಾವ್ ಇದ್ದಾರೆ, ನರಸಿಂಹ ಇವರು KSSM ಎಲ್ಸಿ.
So we can start. Others can join.
Madam, please start.
Yes, sir. A very good morning. Welcome to all for this distinguished guest lecturer on computational biomedicine and engineers candy store, organized by Bites in association with Department of Computer Science, K School of Engineering and Management.
ಆಗ್ಬಿಡಿ.
I, Deepa Yogesh, taking privilege to welcome you all. I heartily welcome our eminent speaker, Professor Gauri Srinivasa, Professor of CSE Department, PS University, Bangalore. Welcome you, ma'am.
Thank you so much, ma'am.
I would like to heartily welcome Dr. KNB Murthy, sir, Chairman, Bites, and Vice Chancellor of Dayanand Sagar University. Welcome you, sir.
Thank you. Thank you.
I would like to welcome Dr. M.N. Vidyashankar, Co-Chairman, Bites. Welcome you, sir. I would like to extend my heartily welcome to Dr. KVA Balaji, sir, Chief Executive Officer of KS Group of Institution. Welcome you, sir. I would like to heartily welcome our beloved principal, Dr. K. Ramanarasimha, Principal and Director of KSSCM. Welcome you, sir.
Thank you, madam.
I would like to extend a warm welcome to Dr. Vandana Jha, HOD of CSE Department. Welcome you, ma'am. And also welcome all the participants, professors from various institutions. Welcome you all. Now I request Dr. Vandana Jha, HOD of CSE Department, to introduce speaker of the gathering.
Good morning. I welcome you all. Today's speaker is Professor Gauri Srinivasa. She has graduated with a bachelor's in computer science and engineering from PES Institute of Technology in 2004 and obtained her PhD in biomedical engineering from Carnegie Mellon University in 2008. Since August 2008, she has served as a professor at PESIT, which is now PES University, heading the Center for Pattern Recognition. She has worked with undergraduate and postgraduate students on various problems, focusing primarily on application areas of biomedicine and healthcare in the field of image processing and analysis, machine learning, data analytics, etc. Madam is a senior member of IEEE and has served as an associate member of the technical committee of bioimaging and signal processing during 2009 to 13 and selected as a member of the technical committee of bioimaging and signal processing for 2 consecutive terms, 2014 to 16 and 2017 to 19. She holds a US patent for a multimodal communication assist device that helps people who are blind communicate with deaf and mute person. Now, I am handing over the session to Gauri ma'am. Over to you, ma'am.
Thank you so much, ma'am. My thanks to Bites, especially Professor KNB Murthy, sir, for this opportunity to speak to all of you, to the principal, management, and staff of KSSEM for organizing this. So very good morning and welcome to all. This is computational biomedicine, all the opportunities that it holds for us as engineers, particularly IT engineers and computer scientists, but across all disciplines. So what is computational biomedicine? The application of computational techniques, particularly modeling and simulation to human health, can be thought of as computational biomedicine. There are 4 important P's that will determine the future of healthcare. And the first of these is predictive medicine. The second is preventive. The third is personalized. And the fourth is participatory. So we look at how computational techniques can actually help us get to this futuristic vision of what healthcare can be. How does traditional predictive medicine work? If we look at traditional machine learning approaches, it's very similar to what a doctor might do with diagnostic medicine. We start off with some input. There is a feature extraction and feature selection that looks at coming up with a description of what has been input. This input would involve collecting some sort of data from sensors when we're talking of machine learning. So it could be in the form of images, it could be in the form of 1D signals like ECG, EEG, EMG, and so on. Or it could be even multiple modalities that put numbers, text, and symptoms described by the patient's patient history, for example, when we talk of text, numbers like blood pressure, heart rate, saturation, oxygen saturation, and we could be looking at images as well, and all the 1D signals that we just listed. All of this could be put together for feature extraction and important features selected, and then we look at what sort of a model suits this problem. And once the model is selected, we build a computational model, and we have to tune parameters for data that is known. So typically this is in what is known as a supervised learning setting, where we drive the model towards something we know is true and correct. And finally, when we're satisfied with the results through cross-validation, we deploy this and test it on actual data. So this is typically the workflow for any traditional machine learning. We can think of the entire first block as pre-processing. This would involve extensive domain knowledge to be able to understand not only just the problem, but also looking at what features make sense, how do we interpret the sensor data, what is noise in that setting, and so on, to be able to enhance the signal, to be able to only extract what is absolutely important and useful. So when we talk of feature extraction, features can be descriptive, but feature selection would help us get discriminative data if we are trying to classify or make some kind of prediction. Training and validation is the second part. It's not to say that there is no unsupervised learning. Of course, we would have methods like clustering to put data that is similar together and separate it out from data that is dissimilar. But training essentially, as we said, is driving the model towards something we know and we understand, and we are trying to get the system to mimic. Finally, when we talk of model deployment, this is the test version. So there is no further training or tuning. We are certain of how this model works, and deployment is really looking at, given some unseen data, what would the labels associated with that be? So if you look at how this is applied to traditional diagnosis, basically a patient turns up with some symptoms. There is some history taken by the doctor. So differential diagnosis is done. And much like any detective work, if you will, a doctor has to figure out what exactly is happening. This is Dr. House, for those of you who've been following this, the presumption is everything that a patient says is not necessarily true. In fact, he says the patient always lies. So it's almost like discovering what could be wrong through a battery of tests and looking at past data and coming up with intuition-based inferences of what could be happening. And that's pretty much the idea with Sherlock Holmes as well when he solves mysteries, right? He's using deduction techniques. So that is where we look at being prepared to be able to see what is wrong and how we can address it. So Louis Pasteur has people ascribe this quote to Louis Pasteur when they say, in the fields of observation, chance favors only the prepared mind. So we try and understand how our minds can be prepared for what is to come. So what does a doctor really do? He would go about this in a very systematic fashion, asking questions on organ systems. Where is the symptom located? The next sort of category of assessment would be whether the pain or condition is acute or chronic, and trying to determine how serious is it, would it kill the patient? The third is it something that is local or is it something that is systemic? If it is systemic, the way it has to be addressed is quite different. Now, with a lot of specialization, we've lost that sense of holistic medicine to look at different organ systems and how they integrate. We end up looking at it in a very local sense, with specialists addressing only the issues associated with their particular organ system or specialties. So generally, teams of doctors work together to ensure the person as a whole can be cured. And finally, there are a whole lot of acronyms that help sort of get to the bottom of what's wrong. And one of them is medicine. For example, they look at metabolic or medication-induced problem, or is it from the endocrine system? Is it something that is a degenerative condition? Is it an infection or ischemia or infarction? Is it congenital, idiopathic? So and so on, right? There's a whole laundry list, and perhaps a lot of tests have to be done to arrive at what exactly is happening. So if we look at this workflow, it's very, very similar to what we would see with machine learning, some of the machine learning techniques that some of you may already be familiar with. So so what would happen in today's context? A patient has some symptoms, and the differential diagnosis is, if it has to be done by the patient or family, the first thing we would do is Google the symptoms. And there are a lot of possibilities to figure out what is wrong, and a little bit of a peek into how computational methods have been useful. So there are several symptom checkers, and one of them is WebMD. So if the age and gender is input along with a whole bunch of symptoms, we could narrow it down to about 100 or 200 possibilities. So they say never Google your symptoms. I'm not sure if you heard of this. There's a small song that came out that said you get 100 diagnoses and medieval prognoses, and every sign is a serious condition. While it might not necessarily be so, and it could really annoy the doctor if we go in with our own version of what could be wrong with us. But this is already starting to show what we could achieve with computational techniques in trying to make sense of all of this data. So rather than stand alone, the theme would be how can we support what a doctor does rather than replace the doctor, which is almost impossible. So how would a symptom checker work? We would start with the input. We would look at what a doctor would normally ask or measure at the clinic if we were to present in person. So the age, temperature, is the temperature high, higher than it's supposed to be, and a whole lot of other basic sort of symptoms. And then we look at a lot of computational techniques that help us separate this out into categories that are known, and finally output whether there is a specific problem or not. In this case, the example looked at is malaria. So with a whole battery of symptoms, using some computational techniques to look at whether the outcome is positive or negative for malaria. And we could think of this as assigning weights or importance to each of the entries that we've taken, and for this particular disease or pathology. So age could have some importance, age less than 40 versus, so you can see there is increasing importance given to age. Similarly, whether one is a smoker or not. So there are different weights associated with all of the different symptoms that are presented. And it could either be thought of as a rule-based technique, which is a ladder of if-else conditions, or visualized as a decision tree. So if the temperature is so much, then something else, so on, right? So it could be a ladder of decisions or a nested if-else tree. And there are multiple examples. So not just with infectious diseases, this could also be done with other types of problems like maybe ischemia or hypertension and so on. So how do we actually come up with a decision tree, or how do we come up with rules? So as we saw earlier, we could compute what is known as the Gini index or entropy, or even misclassification rate if we associate a class label. Someone has malaria is a positive identification. Someone does not have malaria would
Madam, Gauri Srinivas was muted. Just check it out. Hello?
Hello?
Yeah, madam.
Hello, am I audible, sir?
Yeah, you're audible now.
Okay. I think I was muted by mistake. Okay,
Yeah.
so do I have to repeat anything?
Yeah, please do that.
Okay, so so we can compute indices like the Gini index or the entropy, which are measures that help us separate out data in a manner that would increase the classification accuracy. Class labels here refer to the outcome. Does someone have malaria? If it is a yes, that would be a positive class label. And if someone doesn't have malaria, that's a negative label. Or just the absence of that condition. Similarly, for hypertension and so on, it doesn't even have to be binary necessarily. There could be multiple classes in cases of pathologies where there are stages. It could be healthy, stage 1, stage 2, and so on. For instance, diabetic retinopathy is one such condition where there is staging that is done. So we could associate labels with that. So these sort of measures are with what probability or what proportion of the training samples appear in one branch of the if-else condition, and how can we improve the separation by asking fewer questions. So how can we make the questions more meaningful? Is there a way to combine these features, as we call them, or the symptoms, to be able to associate weights with them and ask these questions to arrive at that class label quickly and as accurately as possible? So this is typically how we would build decision trees or come up with rules. And of course, each of these has its own advantages. As we can see, if we were to use something like misclassification rate or class error, that's the curve in red, there is a discontinuity. It isn't smooth. If we use Gini index, this is a smoother separation compared to the class error. And if we were to use entropy, the separation is even more pronounced. So that's generally the method of choice when we are looking at building decision trees. So what is the problem with this sort of an approach? We're trying to fit the data to our hypothesis. We have some notion of what might cause malaria. So we might end up looking for the symptoms we think is responsible for the cause of malaria. And then we're trying to build a decision tree that looks at our training data and tries to mimic the separation. The problem with looking at something like WebMD is the possibility of just too many outcomes. And computationally, it's not possible for us to narrow it down to exactly what is wrong, which is why this is completely useless. And we absolutely need the help of a doctor who would really know the importance that needs to be attached to each symptom, or based on the family history, to be able to decide how significant some observation is, and so on. The other thing is we really have such huge variability that it's really difficult. Unlike with machines, it's hard to build a template human that accounts for all the variations. So each individual is different. And a lot of the papers published in journals like the Lancet and others, it refers to what is the anomalous condition. So under certain circumstances, if there was an allergic reaction to an anesthesia, for example, that is, even though it is just a one-off, that merits being reported, as opposed to maybe in engineering or general computational sciences, where we're looking for statistical significance and how true is it, how much of the data did this condition hold for, and so on. So here the exceptions are extremely important and worthy of note. And it's really difficult to build a model that accounts for all this variation. And variability has multiple sources. It could be because of family history or the genetics. It could be because of someone's lifestyle. It could be just associated with the ethnicity itself. Some races are more prone to certain types of diseases than others. It could be the exposure because of the nature of work, or it could just be someone's individual sensitivity to a certain type of exposure. So the question is, to what extent can we generalize the features and classifiers? And do we have to do everything in an extremely transparent and interpretable manner? If we drop that notion, can we look at other possibilities in terms of features and classifiers and still come up with something that is useful? So taking just one step ahead from our days of rule-based classification or decision trees-based filtering, we could look at extending the idea to other methods. And this is just a tiny sample of what is out there. So here there is one on being able to analyze ECG using artificial neural networks to be able to predict acute myocardial infarction. This data obviously is labeled, and that's how we know how accurate the method is. But the hope is that when new data is presented, the system would perform just as well. Similarly, epileptic seizure detection in EEGs using time frequency analysis. So using time frequency analysis refers to the use of methods like discrete wavelet transforms that look at both the time and the frequency domain. And finally, we have a classification of sleep stages using PSG recording signals. So polysomnography involves multiple sensors as has been listed. So it would have EEG, EMG, ECG, a whole bunch of them, EOG, electrooculogram, and so on. So it's looking at multiple responses as the person sleeps for various disorders. And being able to classify sleep stages is helpful in being able to find pathologies like hypopnea, apnea, and so on, which we will briefly look at later. So all of these are looking at different types of classifiers. It's looking at different types of features. In fact, the one on PSG has been able to successfully classify sleep stages with 81 features. And if you look at the classifiers, there's linear discriminant analysis, support vector machines, K nearest neighbor with weights associated with neighbors, bagged trees, that's an extension of the simple decision tree that we saw earlier, and the artificial neural network. So all of these models have been compared to look at which of these gives the best result, both in terms of sensitivity and in terms of precision. And we can also look at different types of features that can be extracted. Not everything has to be recounted by the patient or measured with a sensor. Some of this could be given EEG signals. We could look at the rolling mean or variance, different forms of powers in that signal. And from ECG signal, there could be interbeat interval that's measured. Again, the rolling mean, variance, and so on. Time frequency analysis like the discrete wavelet transform can be used to extract coefficients, airflow. So we can see that not everything, like let's say the rolling mean or variance or the power, or especially something like the discrete wavelet transform coefficients, can be interpreted in a manner that a layperson can understand. So these are all numbers that are extracted from sensor data. And here's an example of how cross-correlated abdomen and chest signals differ for different types of apneas. The first one is obstructive sleep apnea. The second is a mixed apnea. The third is central apnea, and the fourth is hypopnea. So it isn't, apnea is a sleep disorder where the person tends to stop breathing for some time in their sleep. And it's a condition that can be treated with what is known as a CPAP. And of course, there are a lot of naturopathy remedies as well, like simply walking to lose weight, or different types of pranayama to strengthen the throat muscles, and so on. So if this is caught at an early stage, it would help the person get better quality of sleep and help prevent a lot of other associated conditions like hypertension and so on from developing. So we can see here that no patient can actually describe this sort of pattern or would even know this is what is happening, but this is something computational methods can truly help with given the data. So we needn't stick to just one type of signal. So far, we've only been looking at one-dimensional signals that vary in time. We could be looking at different forms of modalities. For instance, looking at pathology reports is something that could be done. Looking at MRI images, so we could have text, images, there can be video, there can be multiple modalities put together and made sense of. All of this leads to other problems in themselves, like segmentation. If we have to derive something from images, then we should be able to know where to derive this information from. And that leads to this problem of separating out data of interest and removing the background or whatever is not of interest to us from the scene. So that is, for example, automated segmentation of the left ventricle in cardiac MRI. So we should be able to figure out left, right, and also figure out the ventricle, from other structures seen in the chest MRI. This is probabilistic segmentation of white matter lesions in MR imaging. So again, given MR images, figuring out what portion of this is white matter lesions versus the rest of the structure of the brain, that is a very domain dependent study. Here there is automatic lung segmentation and functional SPECT images, and automatic kidney segmentation and ultrasound images. So these are all just, again, the very, very, very tip of the iceberg of all the possibilities of different imaging modalities. And we see that it's the research moving towards including multiple modalities also drove research in image processing and image analysis in terms of improving segmentation techniques and so on. So we have come a little away from our goal in doing all of this. All of this, of course, is towards meeting the end, we hope to achieve, but it has kind of sidetracked our main objective, which was to design something that helps doctors arrive at decisions that are reliable and as quickly as possible. So we did say that we're not looking to replace the doctor. By no means would that be possible or wise. This is only a designing a support system in terms of a way for the doctor to check or narrow down possibilities. So it's the way we've been going about all of this design is to take data of people who've had the condition, take the data of people who medically are not known to have the condition. So that's the class we label healthy. At least as of the time of the study, they weren't diagnosed with that specific condition. So we have that data that accounts for the healthy class, and we have data of people who've been diagnosed with something accounting for the pathology, and systems are built. But what is the use of looking at something when it is evident? Not only a doctor, even a patient may be able to, describe what is going on and arrive at what could be wrong when the symptoms are so evident. So the whole question here is, can we use all of this technology to diagnose before the symptoms are that evident? And here is where we're looking at moving from, it's almost like saying they present the symptoms and a diagnosis is done. But is there a way to monitor a patient, and pre-presentation can we make some kind of prediction? And instead of just twiddling our thumbs waiting for this to come true, can we, if we have faith in that prediction, can we move towards prevention? So this is where healthcare is sort of headed towards. So how would preventive medicine work? It would have to start off with, we won't know what to prevent and whom, right? So the first thing we would have to do is to look at who is at high risk for what conditions, and then monitor them. Especially with progressive disorders, such monitoring is possible. When we talk of disorders that, so we really can't do anything about conditions that develop overnight, but most problems, let us take the example of, heart infarction, for example. There should be some condition of ischemia or lack of oxygen in the heart before there is a heart attack. So most likely the condition is developing, and the moment we can figure out that there is hypoxia or low oxygen, perhaps it's a red flag. And if there is a way to reliably look at the pumping of the heart that is normal versus pumping of a heart that is beset with ischemia, then that is one of the ways for us to figure out, the person might need help, and a possibility of preventing a full-fledged infarction or a heart attack. So monitoring of high-risk groups, and no one would like to subject themselves to invasive monitoring on a routine basis. So preferably these are non-invasive tests that are economical, especially given our context, it has to be affordable. Or even if it isn't, the test, if it isn't affordable, then the test cannot be done very often. So the monitoring wouldn't be as regular as we hope it would be. So those are the small constraints that are there. There is an interesting case study that we were lucky to be a part of for this sort of medicine that is already, being practiced. This is a retinopathy of prematurity. And the team is from Narayan Netralaya in Bangalore, headed by Dr. Anand Vinekar, who's seen in this picture with the baby. This condition, retinopathy of prematurity, is predominant in children that are less than 2 kilograms at birth, and these are prematurely born children that require the use of the incubator. So changes in oxygen levels in the incubator causes an abnormal growth in the blood vessels in the eye that eventually causes, if nothing is done, it could lead to lifting off of the retina and eventual blindness for the babies. So this is something that the doctors seek to address as soon as possible at the stage at which it can be addressed. So the manner in which data is collected is through ASHA healthcare workers. So these are volunteers in typically in rural areas where they weigh the baby, every baby that is born, and they make a note of all the babies that are at high risk that were less than 2 kilo at birth and required the incubator after birth. So this is a very successful public-private partnership. The government of Karnataka has funded this. It's called the KidROP, for Karnataka Internet Assisted Diagnosis of Retinopathy of Prematurity. The team from Narayan Netralaya visits and captures fundus images of the retina of these high-risk babies in various parts of the state. Technicians have been trained to notice patterns, and they flag off whatever is requires a doctor to look at, and such patients get to consult with the doctor. Because this is a progressive disorder, the technician may ask the parents to take a child to Bangalore to see the doctor, and some of these are daily wage laborers. So it costs a lot of money for them to bring the baby to, first of all, a premature baby, it's really small. They have to travel all the way to Bangalore to see the doctor, and sometimes it turns out that is not the week in which the treatment is required. So ROP progresses in 5 stages. The first stage is auto-reversible, so it could even just get back to its own. After the first stage, it needn't necessarily progress to the second. After the second, it needn't necessarily progress to the third. There are certain protocols for when the treatment should be given. Generally, when it is in the third stage, for sure, it's the time for treatment. And fourth and fifth stages are when there is no reversal that is possible. They would only, fourth stage, they would try and save whatever is left of the eyesight. So it could happen that it's only the first or second stage, and the doctor might want to wait for another week. Instead of, the way they treat this is to burn the vessels with laser. So there is impairment of vision when this is done. And this is why the doctors are so conservative in their treatment of the disease. So the parents might go back that week and come back the next week. And again, because it's a progressive disorder, it may not have progressed to the stage where it requires treatment. So they're asked to come back again the third week. And by then they might just lose patience and think, oh, we're just going and nothing is being done. We have to come back, so let's just not go. But that might be the crucial week that they should have brought the baby to Bangalore for treatment. So one of the really nice efforts by the team at Narayan Nethralaya, headed by Dr. Anand Vinekar, is to work with industries like Forus and DHP, that are homegrown industries that are looking at imaging devices and managing the digital data, and working with people who look at image analysis to try and see, is there a way to be able to stage the disease and make a prediction not only of what stage the disease is at presently, but how will this, what is the prognosis? Will it take another week for it to get really bad, or would it revert on its own to healthy condition, and so on. So this, at least they can make an estimate for when the patient should be brought, instead of going back and forth in this manner, and also improving the number of people who are helped. So, so this is a small effort that we made with the study. This is again a static test of data that we got from Narayan Nethralaya. This is in fact an acute condition called aggressive posterior ROP, and it followed a whole lot of, we really had to look at the analyzing the retinal images to be able to determine whether the eye had ROP or not, aggressive posterior ROP or not. And as I said, this is still not at the stage of being able to make predictions in time. This is a static test. So we are working with the team and with all of the collaborators, DHP for the data, Dr. Anand Vinekar and his team at Narayan Nethralaya to better understand the condition and interpret these images and so on. So this is ongoing work. So what is the typical workflow for such, preventive medical effort from a computational team? The engineer would have to meet a doctor who is willing to speak to them. With India, we should respect that the doctor's time is precious no matter where on earth, but especially here, the volume of patients is so high that sometimes it becomes a choice between treating a patient and talking to an engineer. So we first have to find someone who's willing to speak to the engineer, explain what the problem is, identify which problem specifically can benefit from a computational solution. Not all of them are amenable to this kind of workflow. Identify what is the most discernible of stages. So when we say stage 1, stage 2, stage 3 in a progressive disorder, there are certain landmarks or certain features that a doctor looks for before labeling the stages. So we would have to figure out what those landmarks are, because if it's progressing, it's not necessarily in one stage or the other. Finally, we'd have to wait for many, many moons to get the data. And once the data is collected, so this data has to be collected over a period of time. What happens with data like retinopathy of prematurity is that stage 1 data or stage 2 data is available, but stage 3, what happens is they get treated. So we don't actually see any eye progressing from 3 to 4, because that's really against the whole purpose of the whole setup, right? The doctors are trying to help patients, not collect data for engineers. So the moment they see a stage 3, they would obviously treat it. So we would never know what the eye looks like. And, thank God for that. What it would look like progressing from stage 3 to stage 4, if it comes to the doctor, it gets treated. So we would have to look at data where the patient has come in at stage 4 to understand what stage 4 would look like, and similarly with stage 5. And the doctors have their lingo for, for instance, with ROP, they talk about different zones in which this happens. They have different terms like plus, pre-plus, and so on that describe tortuosity or how twisted the vessels are. So all of this that they have, the aids for recognizing what the pathology is, we would have to translate this to some kind of statistical measures that can be used across data. And we'll have to build multiple models, evaluate these against the annotations made by the doctors, go back to the doctor with the results, check if this makes sense. And if it doesn't, obviously we have to redo the entire process at any stage, maybe redefine the problem, maybe figure out what went wrong with the staging, or perhaps the data was too noisy or too sparse, we didn't have enough. So this whole process is iterated. And finally, when we get something, we end up publishing the results, code, and data. But deployment is still a far cry, because there is so much that needs to happen before it can be accepted and actually released or used in the field. So we could actually work with data as, with doctors through the entire process to build the computational intelligence. Or while that is happening on the side, what we can do to be the prepared mind is to look at tons of data that is available online. So some of these have been collected over a period of time. For instance, data for the sleep study includes at least 8 hours of recording of multiple patients, well, I shouldn't say patients, multiple subjects who were asleep, for the sleep study. And this has been annotated by somnologists or sleep study experts to tell us exactly what the features are. So what part of this takes the most effort in terms of computation? It is to understand features, to figure out whether descriptive features would help, or what of those are really discriminative. To be able to make sense of, there's a lot of intuition that doctors have when they look at patients. So how do we tap into that? When they look at the image, they're not looking at pixels or intensities or whatever statistical measure we may be looking at. So how do we capture that and translate it to something that is statistical and makes some sense? And how do we evaluate all of these models with data that is beyond just the limited training set? As I mentioned earlier, prevention type of efforts will always be odds at prediction. So if we predict something and we have any faith in the prediction, we would make every effort to prevent it rather than wait for the prediction to come true. So the effort here is to kind of negate the outcome of our own effort, on prediction. And finally, checking for reproducibility. If worked in one case, will it work just as well in another is a problem that is that really requires some thought and effort. And after all this, ensuring that it can be generalized. If there is some anomaly or some aberration, it would still work with that noise or with that artifact and so on, instead of being highly curated, and it could be reproducible even, but will it work beyond the curated data is something that we would have to look at and make an effort to ensure. So while we're discussing all of this that is very logical and step by step, there was a huge leap with Watson, IBM's Watson. So the machine that was introduced, so it first was introduced in 2011, but really debuted in 2013 when they claimed that it could beat the winners of Jeopardy quiz show. And it was able to collate all this information, make sense, something like the WebMD that we did see. So what can Watson-like systems do potentially for healthcare? And IBM already has a lot of, marketing material that's available. So there is effort that helped reduce how much data had to be looked at when the polio vaccine was prepared by Dr. Jonas Salk. We have detection of defects in DNA. So if this was what happened in 1955, computational efforts from IBM's team was able to detect defects in DNA in 2000. And the hope then was that it could lead to new medical treatments that can, fix issues at a very, very basic level instead of waiting for it to manifest at the organ system level. So all of this really goes back to artificial intelligence, where the first efforts were made in 1950s, trying to use reasoning and natural language to build so-called semantic networks. And always the question has been, can we mimic the way the brain works? So that led to the design of the first neural network. And since then, there has been a whole lot of efforts in this direction. It has been called variously over the years. So maybe AI and then robotics, to expert system, decision support systems, intelligence systems, evolutionary algorithms, machine learning, big data, data mining, deep learning, and we're back to artificial intelligence again. In some sense. So it's been a full circle of this trend. The underlying effort is all the same, trying to look at, can we mimic what a human being does? So the first thing is, when we mimic what the brain learns, the brain isn't learning a bunch of features, or it isn't learning a bunch of models. There is no concept. It's not happening in stages. There is no computing of features or measuring the way we talk of in traditional machine learning approaches. Similarly, learning algorithms are not applied one at a time. It's not as if we think about these things in a linear fashion as we tend to with traditional machine learning. So the first of these sort of wow results that came about was in 2013, when AlexNet proved that it's possible to throw tons of data into a really complex neural network, that eventually became the deep learning, basis for deep learning, if you will, that didn't necessarily look at specific features, but found a way to be able to recognize objects. And since then, there has been a lot of work on what is possible with this these sort of networks that can arrive at results which were previously thought unimaginable with traditional machine learning. Of course, a lot of effort, advances in hardware has also made this possible with GPUs, TPUs, and so on. So this is a similarity search. And here we can see object recognition within an image. It's able to identify person, wine glass, dining table, which is quite impressive. And we've even arrived at a stage where we're talking about visual question answering. Presented with an image, if we ask questions like, how many chairs are there at the table? Or is there a pedestrian in my lane? So the hope is that the system would learn enough to be able to understand this question and give an answer that is reasonable. So it's true that even with medical imaging, even though there is some amount of I should say reservation in using deep learning because it is such a black box, we have seen in certain domains, there are results that have been quite impressive. Our effort in analyzing diabetic retinopathy images was one such, where we ended up getting much higher results with a whole lot of different models that were based on deep learning techniques, as opposed to trying to extract out microaneurysms, hemorrhages, and exudates from eye images. These are different features of diabetic retinopathy that generally looked at, to quantify what the stage is. So using deep learning did exceedingly well in comparison to hand tuning, hand crafting features and coming up with algorithms based on that. So what is the bio part of the biomedicine that we were alluding to? It's not just about understanding the person's condition at a given time. There is a lot of other things that could be done in terms of treatment plans, in terms of drug discovery, in terms of understanding adverse reactions to different drugs, in terms of even synthetic biology, which is something that people have started talking about in that could change the way treatment works moving forward, and synthetic chemistry and streamlining drug development. So this is just another example again from our lab where we looked at how a very simple artificial neural network could be used given the side effects of a couple of drugs. So we know what the side effects are of each drug individually. Can we predict the side effects of the combination of the pair of drugs using a computational model? So the study here looked at the contribution of transcriptometric data, and about 3 months or so after our paper came out on bioRxiv, there was a paper that confirmed this through wet lab studies. That's an independent study. So it's kind of interesting. So neuropathy here is something that wasn't reported in any known source for either of these two drugs, but it turns out that in a combination, this is possible when we put in transcriptometric data as an input for the prediction. So looking to the future, what are we looking at? We're really very far from artificial intelligence as it was envisaged in the beginning. We have to feed tons of data to a system, whereas a child who is naturally intelligent, just natural human intelligence, would learn to identify a dog or a cat without seeing a million examples of each. So can we use transfer learning? Whatever effort is put in one domain, can it be moved to another? In terms of computational power, companies like Google, Amazon have a lot of number crunching resources. Is there a way for universities and small research labs to, if not compete, at least make some small effort without requiring the huge resources that we currently need? So that would be what a hardware engineer could be looking at. And interpreting all of this would be extremely exciting. Why does it work? It's a huge black box. It works is what we know. Why does it work is a mystery. And it's even more difficult to figure out why it doesn't work. There's no way to actually fix it other than change a whole bunch of parameters and a whole lot of possibilities for the number of layers for the network, number of nodes in each layer, the different type of learning algorithms, cost functions. It's mind-boggling. So making some strides towards interpreting all of this and making sense of this is a huge effort for the future. And lack of interpretability. So trust issues. Looking at who is responsible for what comes out of this is the other sort of area in which some work needs to be done. So there is this effort that is termed FATE in AI that looks at fairness. How can we eliminate bias? There are biases in the data that we feed, and this has been a matter of debate. So traditionally, there could be gender bias or any number of biases. And how can we eliminate bias from? So that's what the models end up learning. Models come out being biased. How can we fix that is one thing. Accountability in terms of who is responsible when something goes wrong. For instance, in an autonomous vehicle, let's say a self-driving car, if there is a crash, who should be held responsible? Is it the company? Of course, the machine can't be taken to task. So is it, the programmer? And will we ever get technology that is so advanced if, this is the sort of problem that we have if there's no clarity in something like this? Similarly, in terms of transparency, it's not clear why it works or why it doesn't work, and how can we fix it or improve it? So that is another problem. In terms of ethics, how do we build any sort of morality into the system that is so subjective? And with that, we look at what could beyond diagnosis look like. So prognosis could help with treatment plans, predictive modeling of what could happen in the future, and personalized medicine in terms of predicting one's genetic predisposition, helping towards drug discovery and understanding possible adverse reactions to drugs. So all of this put together could lead to what is known as a virtual patient or a digital patient clone that, this actually came out in November 2019, but there has been a lot of effort for the last few years towards something of the sort that's able to model each individual with all possibilities in terms of what could the consequence of a treatment plan be, what does a certain set of symptoms mean to that person, what would work and what wouldn't. So this is still, rather futuristic in terms of getting it out to the ground and making sure that something like this would benefit people at large. So with this, I thank all the collaborators, Dr. Prashant Attri from CubeBio for our work on computational pharmacology, and Dr. Anand Dinekar for our work with Narayan Netralaya, Dr. Shyam Vasudev Rao and Mr. Akash Narayanan for the work that we have done with Narayan Netralaya, and all the students who've been involved in all the work that I have shared. Thank you again to KSSEM and to Professor Murthy and Bites. There are questions, I'd be happy to take them.
Thank you, ma'am. Thank you, ma'am. Very informative session on predictive modeling and artificial intelligence approach for computational biomedicine across various domains. Thank you, ma'am, once again. So now it's time for open discussion. You can ask any questions to the expert audience. So, ma'am, we have some questions in chat box.
Yes, ma'am.
Can I read out, ma'am?
Yes, please, ma'am.
We have one question from Dr. Professor Srinivas. Do you think we should redevise the scores for Indian population conditions? So we have Framingham Art Study chart is used by most researchers to assign scores for each condition and arrive at the probability of occurrence of a cardiovascular disease. This is based on US population. Ma'am, do you think we should redevise the score for Indian population conditions?
Certainly, I think it's a very valuable question that Sir has raised. Different populations have different propensities to different conditions, and we really cannot have a global scale whether it has been in terms of what what is pre-diabetes in one population or what is obesity in one population versus another. Similarly, the local influences, the type of cooking fuel that is used in various places and so on. So yes, ICMR has been looking at some of these things, and certainly there cannot be a global standard. We would have to take into account what the ethnicity is, and for the Indian population, North versus South, eating habits, lifestyles, rural versus urban. So yes, there's a lot that is yet to be done.
Yeah, thank you, ma'am.
Madam?
Yes.
VKM, madam?
Yes, sir, please.
Madam, this is very hypothetical. I do not know how to ask, but Let me ask, that is bugging me since long.
Certainly.
Life, they say, is think plus act.
Yes, sir.
Okay, while action is captured by our cameras,
Yes,
thinking cannot be captured by camera. We have not yet found the device.
certainly.
And in that mode of logic,
Yes, sir.
if Gauri Srinivasa's picture, if I see, it is only an action picture, not the thinking picture.
Correct.
So if we can research into that thinking picture, which I call it as oral images, EUREL,
Okay.
can we do something about, predicting the personality and also predicting so many things? It's question of device, researching and then analyzing the data that comes out of the oral image of Gauri Srinivasa, for example.
Correct. So, yes, sir. Actually, this is a very interesting question. There is some out of the box effort by none other than Elon Musk towards trying to tap into this and directly communicate with the brain and so on. But
Yes.
again, this is getting into, as you said, an entirely different space of what is mind, what is thought, a lot of philosophy. It's not just physiology. So
Yeah.
maybe brain is really not just the center of consciousness as we know it, or thought. That's what we attribute it to. But so then there's a lot of philosophy also that goes into it. But yeah, that would be a really interesting dimension that would give access to a lot.
Exactly, because this analogy can also be extended to healthy and diseased organs.
Certainly.
For example, a liver, for example, a heart, or for example, a brain. What is normal is something, what we say, if you take a picture of a brain, that deceives you, because besides that physical picture, there must be some kind of unseen, uncaptured things which our instrument has not captured, and the information laden there could be so immense and so deep, which has direct consequences to so many myths and mysteries in the world, isn't it, ma'am?
Absolutely true, sir. Absolutely. In fact, a functional MRI tries to capture what parts of the brain light up during different activities.
Yeah. That is
falls
done.
very
Like, for
short
example,
of-
tumor detection and other things.
Correct.
Even the light has been used. No, my point is, if that particular oral camera comes, we can even capture love, we can capture anger, we can capture so many abstract things.
Correct.
The host of adjectives become physical.
Absolutely correct.
And analysis becomes easier. Yeah,
we're
just a wild thinking, madam. And I'm
very
please don't
interesting,
think me
sir.
I'm mad.
No. I think creative thoughts have to be out of the box and way ahead of times for something.
You see, when these painters, especially these Christian painters, Leonardo da Vinci and all, when they picture the angel, you see, there will be a light aura, behind the head.
Correct.
So that is a symbol of something. Some picture must be there, which is we have not still discovered. Which we have not discovered. Yeah.
Certainly, sir. I think that's a limitation of of science or modern sensors as we know them.
Yeah. The next question, ma'am, is now, for example, we have electronic nose as an electronic device.
Yes, sir.
Which can, mimic our artificial nose and give some kind of data like norm, aroma, index.
Correct.
So the physical force like smell, or physical entity like smell, is put on a two-dimensional picture, right? Okay. Graph. And we analyze the graph and go back to smell and find out how and why that smell has come, what is the intensity, what is the characteristics, and we can always do that. That's what we do for all the images that we get, whether it is EEG, ECG, CT scans, or ultrasound scans and all. They are all, some actions captured. Is it not, ma'am?
Correct, sir. Absolutely.
Now, my point is, when one electronic nose gives some information about the nose, the image, if we analyze it differently, we should get some other different added information. Is it not? Why we should just restrict only to the smell? We can also restrict to some kind of disease associated with the smell.
Correct.
Right? So
Yes.
that if that quality is delineated from the image or feature extraction, as you say, as experts, do in imagery, we get more information with the same picture.
Correct.
Is it not, ma'am? Can we think like that?
Certainly, certainly. So, I mean, especially with the nose itself, I think right now with COVID, one of the symptoms.
Yeah, exactly. I was about to tell you. You see,
yes.
What is the smell of a virus? What is the smell of a bacteria? What is the smell of a particular chemical? Those things we can always get into picture form.
Correct, correct.
And then, go back and try to find out both the preventive aspects and also diagnostic aspects.
Certainly. It's another really interesting dimension that needs to be explored.
And it's question of, some electronics, some gadget to gadget hooking up, right, and then getting the information in a more complex way and trying to analyze and get the combined information, a synergistic approach possibly between the equipments, because these principles happen to be same. Is it not? After all, what we get is image.
Correct.
Yes, ma'am.
It's a matter of figuring out what the right sensor is to capture that information.
Yeah.
Thank you, sir. Thank you, ma'am. Ma'am, we have one more question from Professor Nandini.
Okay.
Excuse me, sorry. Before that, I had posted an earlier question before Professor Srinivasa's. I'm Viraj. I'll ask it myself if I can. So, Gauri, thank you for the excellent talk.
Thank you.
So I just wanted to check, are there approaches to diagnosis that you're aware of that are based on causal models? And the second part, which is kind of linked to what you were talking about, later when you were talking about fate and AI. I mean, I imagine explainability is, really important. So are there, my understanding is that when you move towards explainable models, you usually sacrifice something in terms of accuracy or other relevant metrics. So are you aware of explainable models that are competitive? So causal models and explainable models. Thanks so much.
Yes, sir, absolutely. So as you said, causality is very, very important with diagnosis. So some of the things that they would look for is presence of the cause should lead to presence of the effect, or more strongly, the absence of the cause leads to absence of the effect, or presence of the effect implies there is presence of the cause, and so on. So there are things that have been done, with causal analytics or causal inferences, and a lot of these might still use some of the machine learning models that we talked about, but of course the setting is quite different in terms of they approach this looking at the cause effect relationship, not just the
because those usually require the analyst to first present a causal model. I mean, to basically, so there's so that because my understanding is that those are extremely, of course, in the biological setting, I would imagine those are extremely complex, right? I mean,
absolutely. So so that's where systems biology and other omics like proteomics, genomics, all of these, where they're trying to make better sense. So there's location proteomics, there's a whole lot of different, these omic studies are trying to put in together to say, if this is a small change in the protein, how does it manifest at the organ system level? Or if there is a certain change in the localization of a protein, how would that manifest as any kind of anomaly at the organ system level, and so on. And of course, eventually at the organism level. So yes, that is another entirely different approach, entirely different in the sense of trying to make sense of all of this holistically and from micro to macro, macro to micro kind of thing. So yes, there is effort being put in, high throughput studies, for screening and so on. But yeah, computation is very much required in all of those also. Thank you for bringing that up.
Yeah, and if you have a word or two about the explainable models, that would be great.
Yeah, explainability, sure. So once people realize that this whole thing has been such a black box, people have been looking up at coming up with measures. So with image processing, for example, one of the things with explainability is to again go back to making sense of the features. For example, what is being picked up in which layer, what is the importance. So they found out that some of the lower layers look for directions of edges or certain curves and so on. And as we get to the higher layers, there's more detailing and textures and object dependent features that get added in. So people have been coming up with metrics. There's also this concept of attention that's looking at what is the model paying attention to, so to speak, what exactly is of importance in the data to that model to be able to come up with a label. So how can we quantify all of this? So this is, there has been a lot of effort. And like you said, right now it seems like a little bit of a trade-off. So if you care about the result, we really can't be looking too much into how much sense we can make of the model. But if we want to make better sense of the model, then we would have to sacrifice some amount of, the accuracy and so on. So we need to have enough data and knowledge about both the disease domain, the sensor that collected the data itself, and the model to be able to make all of this work seamlessly. So this is definitely what has captured the interest and imagination of people in AI in the recent times. The last couple of years or so, there's been a huge amount of effort in this direction.
Yeah, thank you so much. And brilliant talk. Thank you once again.
Thank you, ma'am. Ma'am, we have one more question from Professor Nandini. Madam, where do you feel it is best at which stage to incorporate AI rules for better reasoning and analyzation to the doctors?
So that's a really good question also. Right now, looking at static tests seems, pretty simple in terms of it's evident rather than something that's really complicated and that's looking at preventive type of measures. But prognosis is another one. So I didn't talk about a lot of other examples. For instance, there is a lot of effort in cerebral stroke or cerebral ischemia related work where someone presents with stroke. There's a lot of effort that's put into figuring out what the prognosis is depending on how soon someone has been brought in to the hospital. What are the options in terms of surgery versus medication and so on. So these are some of the areas where computation has been trusted to some extent, as a decision support system, and effort can continue to be made. Of course, the final call is always the doctors, the attending doctors and the experts, but these systems do help narrow down options immensely. And there are other areas like diabetic retinopathy, for example, where people have found with a lot of people are not aware that diabetes could have other implications like progressive eye disorders. So every time it's like a kiosk kind of idea where I think Google also had something similar where they said with MIT Media Labs, there could be a goggles kind of thing that someone wears and it simply gives the reading of if there is diabetic retinopathy or not, any sign of it. And the eye is also said to be the window to the body in the sense of a lot of diseases in the body, whether it's with the heart or the kidney. So they do show up as different types of deposits or, like for instance, for kidney disease, there could be yellow deposits in the eye that indicate there is the presence of protein that shouldn't be there. So things like this that could be made use of to diagnose the health of a person without it necessarily being invasive to begin with. So how, dermatology is another, not to say that it isn't, as critical as some of the others, but this is another case where AI can be trusted to some extent. So its physical pictures can be taken and conditions can be figured out. So a lot of these superficial type of imaging studies, as well as studies where there is, for instance, blood reports, electronic health records, all of these, or even sensors, like a lot of fitness watches that are available measure heart rates and other parameters that can be put to use to look at the health or fitness level of people. So these are all places where it can be used with some, they do track sleep, like the Fitbit, for example, or Apple Watch, they track sleep, heart rate, and so on. So some of these models can be used and are sort of being used when we get reports from, the device that we wear, to be able to make predictions without having any sort of, it's not life or death kind of decision, but one that would help a person lead a healthier life or sort of nudge them towards doing the right things. So those are immediate areas where it can be used. And of course, far-reaching ones, you would have to work very, very closely with doctors, to get the right kind of data and to ensure that it's actually useful and not dangerous for deployment.
Yeah, thank you, ma'am. Ma'am, we have some queries in YouTube link. Can I read it out?
Yeah, sure.
Features what we select using feature selection methods, how sure we take up those features further? I mean, how confident we can say those are important features?
So yes, so how can we be confident about the features? We would have to go through feature selection techniques. There are a lot of them. For instance, explicit feature selection involves forward or backward selection, or forward-backward selection, combination of both. So this looks at what is the outcome using one feature alone, or one feature at a time. We start to pick and create the feature set and look at how important each one is. This is an explicit kind of stepwise, discriminant analysis. The other possibility is to use methods like, let's say, lasso or ridge regression, where we could get a lasso, for example, would give weights to different features, decreasing weights as the feature's importance reduce, and ridge, actually ridge gives decreasingly important weights and so on. Lasso helps zero out some of the features that are not important. So there are such feature selection techniques that can be used. There are time frequency techniques or space frequency techniques like wavelets, multi-resolution analysis, that implicitly help if we have a cost function. So all of these ride on what decides how good a feature is. So it could be classification accuracy, it could be entropy. So whatever the metric is, we'll have to look at what subset of features are maximizing that performance measure and take a call on which of these is important. So generally the idea is, right now with deep learning models, throw the entire image in, why would you select features? It will figure the features out for you, which of course, as we have seen, is not easily interpretable for these sort of studies.
Yes, ma'am. Thank you, ma'am. We have one more question. Can we apply data imbalance technique to original data?
Yes, so sorry, that's something I didn't touch upon. Data imbalance is huge. As I mentioned, even with the retinopathy study, we would have lots of data with stage 1, stage 2, less with stage 3, and very less or none with stages 4 and 5. So if we have to build a computational model that is able to recognize the spectrum of possibilities, we would have to look at something like, different data balancing techniques, I would say, or dealing with the inherent imbalance in data. Now we cannot artificially, so yes, data augmentation, synthetic data is something, but again, when we talk of healthcare kind of applications, we'll have to look at how much does synthetic data make sense. When we talk of something like de novo drug generation, perhaps looking at fragments of drugs that already exist, putting them together and looking at how viable it would be in combination. That is something that could be, that's like a computational combinatorial game, so to speak. But when we look at symptoms and so on, it's not like we have to go through an exhaustive list of possibilities, right? Some may be more possible than others. So we would have to design, design something like this carefully. So yeah, upsampling, synthetic data, data augmentation, all of this could be looked at with a little bit of caution, but this is a problem that is here to stay. So we have to look at how to deal with this and get on with a model that is robust and meaningful.
Yeah, ma'am. Thank you, ma'am. Any more questions from audience?
Ma'am, I have a question. Can I ask?
Yes, ma'am.
Yeah. So since I'm working on sudden cardiac death problems, and most of the time this SCD is because of ventricular fibrillation. So I have started working on that, and I have got a very huge data set where I have applied all this pre-processing techniques, feature selection is done. But I'm confused with which particular algorithm, machine learning algorithm to apply. Like, should I go for KNN or should I go for decision trees, or should I go for neural networks? Like, how will I decide upon which to go or which would give me better results, or how do I get over with this problem? Can you give me some suggestions?
So the traditional answer to this with machine learning community would be to just try out as many as you can. And the proof of the pudding is in eating it. So it would be whichever one gives the best result, ma'am. That is the way forward. Unfortunately, if there is no nothing to guide us in terms of what makes sense for a certain domain specifically, this would be the approach of choice, so to speak, to simply try out all of these, tune them to the best that each one can be, cross-validate, of course, for each of them, and look at which is the one that's giving maximum accuracy and minimum standard deviation across cross-validation sets. So that would be the one that is most reproducible of the lot.
Like, should I go for ensemble learning method where I can try out with different algorithms, and the one which gives me good results or accuracy or specificity, should I go with that?
Certainly. So to figure out what when you say ensemble methods, which of them would you put together would be the question again, right? So I think trying out individual methods and then seeing if put in conjunction, if they work better, would be the approach. So perhaps you could start off with what has been proven to work on this sort of data in the past. Maybe start off with that and then look at what methods are people using that is making sense for this class of data.
No, previously in the literature, there's a lot of work on one-dimensional signals. Like, they've worked on ECG and they've extracted few heart rate variability features and all. But the thing is, now I've got a database where I have different vitals, like the BMI, age, all those, some around 40 plus parameters. Now it's a completely different kind of data set. So
Okay,
that's how,
so you would have to find a way to combine multiple modalities. Then it sounds like it's not just one class of data.
Okay.
Right? Is that the thing?
Yeah. Thank you, ma'am.
Yeah.
Thank you.
Okay.
Yeah, thank you, ma'am. Now I request Dr. KNB Murthy, sir, Chairman of Bites and Vice Chancellor of Dayanasagar University, to present vote of thanks.
Thank you. I take this opportunity to thank Professor Gauri Srinivasa for accepting the invitation and also delivering a lecture on computational biomedicine. As for this particular domain is concerned, it's the kind of approach that's been taken and the kind of approaches to be taken in the future. I think Gauri Srinivasa has explained each one of them in detail. I'm sure there are a lot of opportunities for the people to work in this domain. And it more or less very clear that the engineers and doctors may have to work together in the future. before going to a medical doctor, I think they need to go to a engineer doctor to understand the parameters and probably put out a list of things for a medical doctor can look at and probably give the treatment. And it also appears the kind of thing that would happen in the future is to build a digital twin for a human body. Probably as soon as a person goes into a hospital, a digital twin is created. I think the digital twin will be the replica of the human being, where it's going to vary from person to person, and possibly the personalized medicine which has started coming in would be the kind of approach that are the path that would be taken in the future. I'm sure there are plenty of opportunities. It was well explained and obviously put out by Gauri Srinivasa. I thank Madam for taking time of her busy schedule to be with us today morning to talk to us and explain the hard research work and also the kind of possibilities in computational biomedicine. I also take this opportunity to thank Professor Balaji, the CEO of KS Group of Institutions, Professor Ram Narasimha, the principal of KS School of Engineering and Management, and also Dr. Vandana Madam for organizing this lecture from KSSCM. And we sincerely hope the participants have benefited from this lecture and use some of this, the inputs given by Gauri Madam for their research work in the future. And finally, I thank one and all. All in all, there are about 100 participants in the Zoom, and there are a good number of participants in the YouTube who attend this lecture. And there'll be a lot of lectures that are going to come up from Bites in the future as well. Request the similar kind of cooperation in the future, and we will ensure that we get a good number of information for us to work on. Thank you. Thank you very much.
Thank you, sir. Thank you, Gauri ma'am, for such an informative and descriptive talk today. Thank you all once again for attending this DGL organized by Bites in association with KSS. Thank you. Thank you, one and all.
Yeah, there's one more lecture coming up on Wednesday by Dr. P.G. Divakar from a former scientific secretary of ISRO. He's going to talk about Indian satellites and its applications on Wednesday morning, same time.
Okay.
Thank you.
Okay,
Thank you very much.
Thank you. Thank you, one and all. Thank you, sir.
Thank you.
Thank you, ma'am.